Today, I welcome Dr. Noroozi, who's a periodontist in Vancouver, British Columbia, and he has a study club of general dentists in Vancouver. And he's going to show us a very interesting case that he believes has got learning for us all. Mehdi, what's the case about, and why are you showing it to us?
Hi, John. Thanks for having me here. I'm glad to share this case with my colleagues because I believe a very nice case has gone wrong because of a very simple mistake. And there are some times that we think some things that we do in dentistry are going easily forward and there will be no problem, but very small, tiny mistakes then actually can ruin a very major procedure. And that's why I want to share this with my colleagues to ensure that do not take anything lightly in dentistry. Sometimes very small, tiny thing that you think it's going to be all right, it may actually cause lots of problems for your case.
So the devil is in the details, eh?
Yes, that's right.
Let's go have a look at your case.
Sure, John. Thanks for having me here. I'm very happy to share this case that it's been co-managed by myself and my colleague. It's about a single implant that has been facing some complications, but I found the experience very interesting for everyone doing implant dentistry, that sometimes very little mistakes may have very large consequences. So we are going through the case. A patient came in to see the dentist with the complaint of occasional pain, pointing to tooth number 1-4. And what do you see, John, on this radiograph?
Well, I see a very heavily restored 1-4. I see it's been root canal treated. I see what looks like a pretty deep pocket on the mesial of that 1-4. I see a couple of implants distal to that, and bone loss around those too. So.
Perfect. That's great. Also, it's a very alarming thing here because when we have implants and in neighboring implant area, we have a tooth with some problems like 12 millimeter pocket on the mid-buccal aspect.
Right.
And patient experiences pain. So this issue has to be resolved because the bone loss around the tooth and the infection around the tooth can actually spread to the neighboring implant and jeopardize the longevity of those implants. So we have to take very quick action regarding this tooth. So patient came in, dentist did examination, 12 millimeter pocket on the mid-buccal aspect, 7-8 millimeter pockets on the mesial and distal aspect with bleeding on probing was noted. So tooth number 1-4 had M2 mobility. And as you mentioned, the tooth had root canal treatment. And as you see here, there is a mesial area of radiolucency. Most likely, this radiolucency is spreading to the mesial forcation of this molar. So the diagnosis was the vertical root fracture, and the decision was to remove the tooth. All the options were discussed with the patient, and patient opted for implant therapy in the area 1-4. Patient came to the dentist's office, the tooth was taken out, and at the same appointment, implant has been inserted in the area of 1-4. When you're looking at the image on the right side, what do you see, John? What's your opinion about the position of this implant relative to the neighboring anatomy?
It looks to be really close to the tooth beside it. It's almost as if it's like the root tip. Pretend root tips are touching, right? The tip of the implant and the apex of the canine seem to be very close.
You're very right, because the canine tooth has a distal curvature on the root, and when we are placing implant in the area of 1-4, we have to be very careful, because if we follow the angulation of the crown of the canine, we may actually be in the problem position. So we have to constantly check the implant position by taking radiographs at the time of implant insertion.
Of course, when you look at the other radiograph there, you don't have that appearance of proximity so much.
Exactly. So this is another good point that PA radiographs sometimes are very misleading in terms of interpreting the position of implants.
Right.
So as you mentioned, on the right side, implant seems to be super close to the root of the canine, as opposed to the left side, the same implant, the same site, but looks like the implant is in the better position relative to the root of the canine. All right. So the implant was placed, the cover screw has been inserted, and the wound was closed, and the patient went home. Everything went very well. There is no indication of any problems during the post-op time. And patient came back for the second stage surgery. The implant was uncovered by the dentist, and a healing abutment has been inserted over the implant.
Right.
And this picture, these two pictures, one is from the occlusal view and the other is from the buccal aspect, shows the photo of the area almost 2 months after the insertion of the healing abutment. Can you please describe what you see, John, on the left?
Well, like on the distal buccal side of the, just right in front of the 1.5 there, I see a red swollen area, like with, you know, is there a fistula there or like an abscess? Like there's acute inflammation there. Anyway, it looks like.
Yes, you're right. And this patient has started feeling some pain in that area, and she's experiencing some discharge coming out of that place. So as you mentioned, it looks like we have a sinus tract. The implant was totally fine. Everything was totally okay at the time of the second stage surgery. The healing abutment has been inserted about 2 months ago. And as you see here, we have some issues going on the distal aspect.
Yeah.
So this is from another view. It's a closer view. So we actually probed this sinus tract, and it goes 12 millimeter deep. It's almost to the tip to the apex of the implant. So
the radiograph there, look at the huge area of bone loss distal to that 1.4 implant area. Yeah.
Exactly. What else do you see, John, on this radiograph?
Well, it's like sort of where the cap is on, like there's a gap there between the healing cap and the implant itself.
Exactly. So it seems like the healing abutment or the gingival former has never fully seated on the implant. And this actually can cause a problem because now we have a big screw hole, which is not sealed properly, and bacteria can pump in and pump out very often. And this area is not cleansable by patient. It's a very good reservoir for bacteria. And this bacteria now has caused tremendous amount of bone destruction on the distal aspect of this implant. So this case was referred to me at this stage. So I was hoping that I can do some peri-implantitis treatment to save this implant. So we have some bone loss on the distal aspect. This implant position is right. As you see, it's slightly closer to the canine root, but it's much better than what we were seeing on the first pre-apical radiograph.
So when you see that patient, just would say you had that evidence, you'd still have in your mind, I can save this implant. Would that be still in your mind at this stage?
Well, you know, when an implant is placed, it's extremely difficult to convince the patient that this implant has to be removed. If the implant can be saved, that would be great. But we have to make sure the implant is osseointegrated first. If implant is not integrated to the bone, then there is no way we can save the implant.
Yeah.
I could not find any mobility with this implant clinically. So basically, our diagnosis was we will decide at the time of the surgery if this implant has to come out or not. So we had this discussion with the patient that if implant is fully integrated to the bone, we may decide to save the implant. Also, we discussed the alternative option of explanting the implant, removing the implant, and then we do start again from scratch.
Right. No, I just thought when I looked at that radiograph there, I says, "Wow, that looks like a sort of a hopeless case." But I'm interested that you could even give it a sporting chance. Or
So basically, we discuss all the options with the patient, and as you see here, 12 millimeter pocket on the distal aspect, suppuration is present. So we have active acute infection going on the distal aspect. And as you mentioned here, we have unseated healing abutment. Upon surgical entry, I did the toric test for this implant, and unfortunately, this implant was not osseointegrated, or maybe the integration was lost as a result of the infection.
yeah,
So I cannot tell at this point, because I believe the dentist did the integration test at the time of the second stage surgery when they switched from the cover screw to the healing abutment. And the implant may have been integrated at the beginning, but as a result of the infection and tremendous amount of bone loss, the integration might have been lost. So I removed the implant, and as you see here, this is where the implant has been located. And you also see a huge destruction of the buccal plate and also the interproximal bone here.
yeah.
It's a huge destruction of the bone, which is corresponding to what we saw on the radiograph.
So you're going to have to put something in there if you're going to maybe do another implant. You're going to have to get some bone grafting material in there or something.
Exactly. So in this case, because we had an active infection, I decided to postpone the bone grafting. I explained to the patient, if we do bone grafting at this stage, there might be a chance of bone graft infection, and the bone graft might not be successful. So we decided that we do not do anything here. We just remove the implant, clean up the defect, remove all the granulation tissues, and by cleaning up the wound, we closed it, and this is how it looks like right after the surgery.
Right.
So we brought the patient back in 2 months after the implant was removed. And as you see here, we followed the GBR protocol using allograft and collagen membrane.
Okay.
Instead of doing vertical incisions, I decided to extend my flap laterally, so I actually get better aesthetic outcome by removing the need for vertical incisions.
Right.
And this is right after the surgery. The wound is fully closed. We got the primary closure, and this CT scan was taken 5 months after the bone grafting was done.
So what am I looking at in the different images there?
Well, on the right, actually the below image shows the slices of 1 millimeter apart from each other from the area of implant. So as you see here, this is the image that we have from the area of 1/4. You can see the integrity of your buccal plate.
Yes.
So that's your buccal plate. So it's very integral.
Yeah.
And also the palatal plate. And you see very good amount of bone thickness and width.
Both, buccal and
exactly. And then you actually see the slices here. So this is a slice number 1.
Yes.
Slice number 2, and as you go, slice number 3, and this is actually all the slices from 1 to 6.
Thank you.
Shows where the implant is going to be ideally positioned. So now we have a very good bone in the area. We can confidently plan this case with a new implant with a good bone, hopefully. But we still do not know if this is a real bone or if it's just some bone particles, right? Because it's not clinical. It's just a CT scan. It shows some white spots there.
Right. So you're going to have to leave that for some time, right?
Yes. And then this is what we see. This is at the time of the surgery. Here what I did the papilla sparing technique to preserve the papilla here, because I don't want to do intrasulcular incision to detach the fibers from the neighboring teeth.
Right.
I will go with this technique because I want to keep this papilla still attached to the neighboring teeth for better aesthetic outcomes.
Yes. Especially towards the front, yeah.
Mm-hmm. Exactly. And now look at this bone. It's bleeding,
Beautiful.
meaning that the bone is vital.
Yeah.
We have the good contour of the bone. The integrity of the bone is perfect. The bone was hard to drill. It means that the bone graft was fully integrated to the native bone. So
How long did you wait between doing the bone graft and what we're seeing right now?
That's a very good question, John. Depending on what type of material you use. If you use autogenous bone, patient's own bone, you can actually go after 2 to 3 months of bone grafting. If you use any sort of allograft materials, you want to wait for 5 to 6 months. If you want to use any sort of xenograft material, you want to wait a little bit longer because those materials have lower substitution rates. And if you use any synthetic bone graft material, you still want to wait longer. Right. Because those cases, if you go earlier, there is a possibility that the bone seems to be very sandy and you cannot achieve a good primary stability for your implant. In this case, we waited for 5 months and a half.
So during that 5-month period, did the patient have any sort of a temporary prosthesis, or would they just have a space there?
No, the patient had a partial acrylic denture.
Okay.
That was a very good question. I mean, this is a part of the patient's aesthetic zone, and patient could not go with no tooth in the area. So patient had a small partial dental prosthesis, as we know as a flipper.
And of course, you're hoping that that doesn't do more harm locally than good, you know. So that's just the thing that's on my mind there is.
Exactly. So we constantly check this patient. So the most important thing is you want to make sure the buccal flange is not pushing against your bone graft here. So we actually reduced the flange here, and we constantly see this patient. You should see this patient very, very often to make sure the denture is, first of all, stable, and secondly, it does not push against your newly placed bone grafting. Right. So we recommended to the patient for the first 2 months of bone grafting, they actually stay away from the denture as much as they can if they're home, and if they don't need to put that flipper or denture on, they stay away from it. But if they have to socialize and they need that denture, so obviously there's no other ways. We also discussed the option of partial, like Essex provisionals. We also were considering sort of a Maryland bridge made of composite or ceramic. But because of the case was actually, at this point, was very expensive for the patient. So financing was a little bit
kept it as simple and as non-invasive as possible. Yeah.
Exactly. Yeah. So we decided to go with the partial denture. So the implant was inserted, and 2 months after, this is the radiograph, as you see here, about 2 to 3 months after the implant insertion. So there are two actually points here. The first is look at the angulation of this implant relative to the neighboring implant and the tooth.
Well, it's in the same plane. There's not a convergence anyway, it seems, yeah.
Exactly. So it's extremely important that when we place implant in the area of the first premolar, we always consider the angulation of the root of the canine, because if we follow the crown of the premolar, and if we actually angulate in a way that we want to be parallel to the crown of the premolar, it's very likely that we end up in the root of the canine. So we have to be very careful when we actually do the implant in the area of premolar. We make sure we consider there is the curvature or the root of the canine.
Yeah. Mm-hmm.
So patient was happy, everything went well, and also in this case, the patient decided to change the crowns of the neighboring implants. So my restorative colleague, he changed the crowns of those 2 implants. These are older implants, and then they made the new crowns for those, and also the new crown has been placed for the implant in the area 1-4. So basically, John, my question is for you, what do you think this problem has happened? I mean, why this problem has happened? I mean, how we could have prevented all of these multiple surgeries, multiple procedures for this patient at the beginning?
Well, I'm just taking my cue from something you said earlier. This the whole concept of that healing abutment not going fully in and it being a real reservoir for bacteria. So hard to clean area. Just that certainly is one thing. And I guess it was just the way that implant was placed. The initial implant was placed. I think the angulation of it, hard to clean area, and then the mismatch between the implant and well, the potential mismatch between the implant and the healing abutment.
Exactly. So I believe the mismatch between the healing abutment and the implant was a big issue here. I spoke to my colleague and I realized that there was the order of the healing abutment was not right. The implant was a platform shifting implant, meaning that the size of the abutment and the healing abutments should be smaller than the implant shoulder. But in the first case, they used a non-platform shifted healing abutment for an implant which was designed as a platform shifted implant. And because this healing abutment was not fully seated, then there was a big reservoir for bacteria. In my own practice, I use chlorhexidine gel 1%. I prescribe it through a local pharmacy here. They make the gel for me. And there are some studies showing that anytime you put your healing abutment or your final crown, if you put a small, tiny amount of chlorhexidine gel inside the screw hole, that actually reduces the number of bacteria in the screw. And also,
it doesn't just wash out immediately. Does it have a long-lasting effect?
Chlorhexidine has some long-lasting effects, even in the mouth. The effects can stay up to 2 weeks. But the point is, the first time that you insert the healing abutment, you still do not have good soft tissue attachment to your implant components. So the implant at the beginning, it's more likely to be predisposed to the bacteria inside the mouth. So you still do not have attachments to the components.
So would you ask the patient to maybe apply some of that gel afterwards, like after they go home or anything like that?
I don't think they can do that because the area that I'm talking about is this.
Oh, well, right inside the screw, yeah.
Yeah, so no worries. So basically what happens is when we insert the healing abutment or cover a screw or the final crown, just a small, tiny amount of chlorhexidine gel is going to be placed over the threads of your screw.
Exactly. Inside, yeah, okay.
I know some clinicians actually they torque their healing abutments to 20, 25 Newton centimeter as well. But it's in some implant brands, it's not recommended because the company says you should not do any torque except for hand torque for healing abutments. But some people, they torque it to higher levels in order to have better seal and security. But my point is always pay attention to the components and also take radiographs as necessary to ensure your implant components are fully seated on your implant shoulder. Because sometimes a small, tiny neglect may actually cause a huge destruction. In this case, we had to lose one implant because of the infection happened due to presence of tremendous amount of bacteria in the area.
Right. So that was when were those photographs taken, and how's the patient done since?
We've been following this patient ever since the crown was placed, and she's happy. The probings are within normal limit. The sinus tract is not present anymore, and the radiographed patient is coming. I believe in a few months now for another radiograph to ensure the bone around the implant is stable. I expect this case has a good prognosis in long term because everything is stable at this point. But this is another thing for all implants. We have to put the patients on very diligent recall examination. So patients have to be seen once a year. And this is something that we all have to communicate with patients, that implant need actually care after insertion. It's right that implants do not get cavities, but implants may get bone loss.
Right.
And the bone loss happens, we all know peri-implantitis is the disease of the century.
Right, we hope.
More and more.
So maybe when the patient comes back and you take a new radiograph, we could get together again, and you could show us the post-op, and maybe some practitioners who might have some questions about the case would be able to join us in a meeting like this, and have a little Q&A.
Absolutely, glad to do that. Thanks, John.
So you use Facebook for your practice. What are your goals with your Facebook place for your practice? And is it aimed at patients, or is it colleagues and an opportunity to share information?
So what I do on my Facebook page is mostly I'm sharing the cases as I go, because I have a study club here in Vancouver of 28, 29 dentists. And as I see cases day by day, there are some interesting educational cases, in my opinion, that I want to share it with all colleagues, because we don't have to experience all the mistakes ourselves. We can learn from each other. We can actually spread the knowledge. And there are some cases that we are doing in our practice, and I want to share them, what we started from and what are the goals of the treatment. And after the treatment was done, what we have achieved. Like there are some cases that about the soft tissue grafting or the implant therapies. That's my goal. It's more about educating patients as well as colleagues to know what we offer in my practice.
Right. And so just one final question, is just like going over it again. For this case you've just shown us, what's the one big take-home message?
The big take-home message is don't take anything in implant dentistry lightly. You did a great job with your implant surgery, you placed your cover screw, but there is a small, tiny healing abutment that destroyed the whole case. So in my opinion, yes, you might have a very busy schedule at the time of doing second stage. Second stage surgery might be very simple, straightforward procedure, and you actually may say, okay, I don't need to take a radiograph to verify sitting my component there, and then this problem happens. The other take-home message, I believe, is follow up with the patient. So make sure you bring the patient in on a regular basis to make sure you monitor the situation. If you do second stage, if you do implant surgery, you make sure you have very good follow-ups right after.
Right. Dr. Mehdi Noroozi, thank you very much for this very interesting case presentation.
Thank you, John, for having me.